connected by purpose, driven by passion. Welcome to the Spark Live webinar series, where we gather to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities. Keep up to date on all of Children's Healthcare Canada's webinars, events, and announcements. Sign up for our Spark News e-bulletin by visiting our website at childhealthcan.ca and follow @childhealthcan on Instagram, X, and LinkedIn. Now, on to today's webinar.
Hello, everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for this webinar. I'll begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin Anishinaabe peoples. We recognize and deeply appreciate their historic connection to Ottawa. And today, Ottawa is home to Indigenous people from across Turtle Island. Children's Healthcare Canada is committed to forging new and deepening existing relationships with First Nations, Inuit, and Métis peoples. We are grateful for the opportunity to share this land as we work to measurably improve children's health and healthcare from coast to coast to coast. I'm delighted today to speak with colleagues from BC Children's Hospital. Dr. Matthew Carwana and Dr. Nita Jain will present Child Maltreatment in Young Children, Evidence and Insights from the Pandemic. Dr. Matthew Carwana is a pediatrician and clinician-investigator based on unceded Musqueam, Squamish, and Tsleil-Waututh territory and the medical director of the Social Pediatrics Program at BC Children's Hospital. He provides care in Vancouver's downtown east side and is the co-lead for the Indirect Consequences Project, part of the Popcorn Research Network, to which Children's Healthcare Canada provides knowledge mobilization products and services through its Spark Impact program. Dr. Nita Jain is a general pediatrician and the medical director for the Child and Family Clinic at BC Children's Hospital, which offers support for children and youth who may be at risk of physical, sexual, or emotional harm or neglect. Welcome all to this webinar, and it's now my pleasure to pass the mic to Dr. Jain.
Great. Thank you so much, Paula. Good morning, everyone. Thank you for joining us today for this presentation on the topic of child maltreatment in Canada. Next slide, please, Matt. Thank you. Dr. Carwana and I are both honored to be joining you from beautiful Vancouver, a city situated on the traditional, ancestral, and unceded homelands of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh nations. We acknowledge our place here on the traditional territories of First Nations communities as an expression of cultural humility, that we are privileged to use and share this land. As healthcare professionals, we recognize the systemic racism within and throughout our institutions, and that we have the responsibility and power to create culturally safe and appropriate environments of care. Next slide, please. Let me first start with the question, what is child maltreatment? Well, child maltreatment is defined as harm or risk of harm to a child or youth by anyone acting in the role of a caretaker. So child maltreatment can be either an act of direct commission, such as inflicting force upon a child, or it can be an act of omission, as in the cases of neglect, where a child does not receive the necessities of care, or there's a failure by an adult to provide the necessities of care. In Canada, child protection is a provincial responsibility, and as such, every province and territory has its own child protection legislation. And in recent years, the laws of many Canadian jurisdictions have been updated to recognize the inherent rights of Indigenous peoples to self-government and lawmaking authority. So in these jurisdictions, there are now Indigenous Child and Family Service Agencies, which have or will shortly be taking on the responsibility of child protection matters in their communities. These are agencies that are still evolving throughout Canada. And it's important to know that reporting of suspected child maltreatment is universal and is mandatory in Canada, which means that every citizen is responsible for reporting concerns to their provincial or territorial child welfare agency. I will elaborate a little bit more on this later on in the presentation. Next slide, please. It's often helpful to think of child maltreatment in these 5 categories as they are defined in provincial child protection legislation. So we talk about physical abuse, where excessive force causes physical injury to a child; sexual abuse, any sexual act or exploitation involving a child. We can talk about emotional or psychological abuse. These are behaviors or words used by adults that are caring for children that harm the self-worth or emotional well-being of a child. As I mentioned in the previous slide, on acts of omission, neglect is the failure to provide basic needs such as food, housing, medical dental care, education, supervision, and safety to children. And then in recent years, exposure to domestic violence has also been included as a form of child maltreatment, recognizing the potential harm to a child when they witness violence in the home setting. It's important here to note that a child can be a victim of multiple types of abuse at the same time. That is to say that different types of abuse can coexist in one scenario. Next slide, please. How common is the problem of child maltreatment in Canada? Well, in 2019, Fallon and colleagues published the 4th Canadian incident study of child abuse and neglect. This study was funded by the Public Health Agency of Canada and really is a definitive source of nationally aggregated incidence data on child maltreatment in this country. The study showed close to 300,000 child abuse investigations took place in 2019 in Canada, which translated to almost 50 investigations per 1,000 children. In just over 1/3 of the investigations, abuse was substantiated, and in another 4%, abuse was suspected but could not be substantiated. And the result of these investigations led to out-of-home placement for children in about 5% of cases. Of particular note and new for the very first time in the 2019 study, previous studies had been done in 2008 and 2003, and I believe 1998. For the very first time, the incident study looked at the rate of child maltreatment investigations in Indigenous populations in Canada and found that the rate of investigation for Indigenous children was 3.6 times higher than for non-Indigenous children. And this information really has been instrumental in fueling the efforts to create Indigenous-led, culturally relevant child welfare supports for Indigenous children in this country. Next slide, please. Unfortunately, the consequences of child maltreatment are many, and not just for the impact on the child and the family, but also for society at large. I've listed here a few examples of the impact on a child's physical and mental health, and also on the resulting social issues that can have broader reach in society, such as substance use disorder, aggression, perpetration of violence on others in these children as they grow. Of course, the worst possible outcome for child abuse is the death of a child. An analysis of Canadian data published in 2025 identified 359 deaths in this country due to child maltreatment in the 10-year period between 2007 and 2016. That number represents a staggering 20.4% of unexplained or homicide deaths in children under the age of 18. With that sobering statistic in mind, I will hand over to Dr. Carwana to present the results of his recent study on child maltreatment hospitalizations in Canada for children under the age of 2 during the COVID pandemic.
Thank you so much, Nita. So, as mentioned in my bio, my name is Matt Carwana, and I'm a pediatrician and also a clinician investigator at the BC Children's Hospital Research Institute. And I had the great fortune of becoming connected with the Popcorn Network upon its inception in 2022. So as briefly mentioned, Popcorn is a network of networks bringing together pediatric researchers across disciplines that provide care predominantly in a hospital setting. So inpatient pediatrics, emergency pediatrics, critical care pediatrics, and infectious disease pediatrics. And our initial funding in 2022 through the Canadian Institutes for Health Research, we were asked to try to identify how the COVID-19 pandemic and COVID-19 itself was impacting children and youth. And so myself and my colleague, Dr. Nadia Roumeliotis, were asked to co-lead a project around the indirect consequences of COVID-19 on child and youth health. And our primary knowledge user, it was the Public Health Agency of Canada. And they specifically asked us to look at kind of 2 areas or 2 primary categories of conditions: mental health conditions and child maltreatment. And my colleague, Dr. Meliotis, presented earlier this year a webinar on some of the mental health impacts, specifically eating disorders that we identified through our scholarly work. And I'm here today to share our work on child maltreatment. I'll just share that the results of this study were just accepted for publication in CMAJ, so should be forthcoming, hopefully fairly early in 2026. So our main study question was to see how the COVID-19 pandemic may or may not have impacted rates of child maltreatment hospitalizations during the COVID period. And I want to be really clear that we're looking at hospitalizations only here, so it's difficult to necessarily extrapolate this data to population-wide levels of maltreatment. And when we get to the numbers, I'll share that a little bit further. We were able to create a data set using mostly data from the Canadian Institute for Health Information, or CIHI, partnered with the Institut National d'Excellence en Santé et Services Sociaux, apologies for my bad French, but for the Quebec data, and effectively constructed a 7-year data set ranging from April 2016 to March 2023, so about 4 years pre-pandemic, and then those kind of core pandemic years, and maybe about a year or so that we'd consider to be during the pandemic recovery period. For the purposes of this study, we decided to focus on children specifically under 2 years old. There was a couple of reasons for that. As you'll see shortly, the codes that we use in the discharge abstract database that code for child maltreatment include a lot of codes for sexual assault or assault that in older children can be applied both to maltreatment, but also in peer-to-peer situations. And so we wanted to be as specific as possible that we were looking at child maltreatment from caregivers, hence selecting kind of sort of this most specific age range of under 2 that we had in our data set. And secondarily, we do know that the consequences of maltreatment and the rates of specifically mortality are highest for this age group. So we combined the health data that we received from the Canadian Institutes for Health Information and CIHI, and INES, specifically the discharge abstract database information, which is information that comes from hospital discharges and is extracted by hospitals and sent to CIHI after hospital discharge, and then combine these with additional statistics and data that were available from Statistics Canada and CIHI. And generally, what we looked at were rates of admissions per population, and those population estimates were provided to us by Statistics Canada. So in terms of what we looked at, we used a set of what we call ICD-10 codes. So these are codes that are input based on the discharge diagnosis from the discharging physician or nurse practitioner at the time of hospital discharge. They're grouped into like kind of broad groups. And so I'm not going to list these all off here, but I did just want to show the codes that we included for the purposes of this study. Specifically, we included those that were confirmed maltreatment syndromes or neglect and abandonment syndromes, but also those for children that were being admitted for examination for possible neglect, as well as, and these were much less frequently coded, but this broad category of other problems related to upbringing, including things that could be neglect, like inadequate supervision, and things that were confirmed neglect, such as emotional neglect. So just to clarify that all of those kind of 5 categories that Nita captured or mentioned in the introduction would have been included in this study. Scientifically, our primary exposure was the COVID-19 pandemic period. So our big question we were looking at was, did trends in hospital utilization for child maltreatment change during the pandemic period? So from March 1st, 2020 to March 25th, 2023, change compared to that pre-pandemic period from April 3rd, 2016 until February 29th, 2020. We were also interested in knowing, I know we can all remember that initial kind of early phase of the pandemic was associated with particularly stringent public health measures. And I didn't include the graph of pandemic stringency by province. We have all that information for those that are interested and want to connect with us. But we certainly noted that the initial 16 weeks of the pandemic were associated with very high rates of public health measure stringency across Canada. And interestingly, in our prior mental health study, had seen clear signals of differences in health presentations during that phase. So we did specifically as well look at this initial 16-week phase when we think of things being really like shut down, is often the terminology that we would use, I think, in the community to discuss this. We also included the calendar month of hospitalizations to assess for potential seasonality. And then through the Canadian Institutes for Health Information and Statistics Canada, we're able to extract for each admission some relative sociodemographic data. So basically an index of material deprivation that is based on the patient's postal code. We ourselves did not have access to the postal code. We just had the relative deprivation index linked to each admission, as well as some information regarding where the patients came from geographically in terms of coming to care, whether they were admitted to a pediatric hospital or a community hospital, et cetera. And our statistical approach was called interrupted time series analysis. And I'm not going to get into the weeds of this, but effectively, the purpose of interrupted time series analysis is to see whether there's a change in the expected trend before and after something happens. So you basically average or identify what is happening with the rate of hospitalizations during the pre-exposure period. So in our case, the pre-pandemic period from April 2016 to March 2022. You model out what you would expect to happen during the exposure period or pandemic period. So, based on those first 4 years, what would we have expected to happen for the hospitalization rate based on the trends? And then we include in the model, of course, what actually did happen and see if there's basically a difference between what we expected might happen based on the statistics, based on the data, and what actually happened. And that's really kind of the core of this project, seeing if there was a difference in what we expected in the trend. And the reason that's nice is that you can actually examine and capture trends that are already changing over time prior to something happening. So if we think about the mental health work that we did, we know that rates for mental health hospitalizations were increasing pre-pandemic. So it's not enough to say, oh, our mental health rate's going up during the pandemic period, because that might just be a continuation of an existing phenomenon. What we're able to do with this approach is, as best as possible at least, compare what actually happened to what we expected to happen based on the preceding years. So hopefully that will make sense when you see kind of some of the data and some of the slides. I'm going to skip over the specific analytic approaches we use, but they're there on the slide for anyone that is a statistical keener. So just looking right now at our annual rates of hospitalizations for child maltreatment per 100,000 children aged less than 2 in Canada, as you'll see just kind of at a quick glance overall, really the overall rates for hospitalization have been pretty consistent, maybe with an overall trend to slightly decreasing between 2016 and 2022. So the average rate is about 27.7 per 100,000 children per year. Overall, there is a general trend of more male children than female children being admitted, which is something that I know folks that practice this, like Nita, definitely see in clinical practice. Although the majority of admissions come from urban environments, there's a higher rate of these hospitalizations for children that are living in rural or remote communities. So even though the absolute number of admissions coming from those communities is lower, the average rate is actually higher. Which is, I think, just an important thing. I'm really interested in how we plan our health system in Canada. I'm sure many of us on this call are. And that kind of means that a lot of children that end up hospitalized are probably living far from the pediatric hospital where they may require kind of tertiary level care. And actually, the last thing I'll just mention about this slide, and just when we think about numbers and the fact that I really wanted to make it super clear that hospitalizations are the tip of the iceberg. You might recall from Nita's slides a couple slides back in that paper from Barb Fallon on the incidence of child maltreatment, that I believe there was something like 40 investigations per 1,000 children. The rates of admissions are more like 20 children per 100,000 children. So like 100 times the magnitude. So really, we're looking at the very tip of the iceberg in this study. We're looking at the kind of most severe piece, which I think is really important, but just wanted to make the magnitude of those numbers really, really clear because I don't want to misappropriate the data or what we're kind of looking at here. Anyways, going into what we see in terms of trends, you see here our total hospitalizations, which similar to the rates are kind of steady versus maybe slightly decreasing over time. And the vast majority of admissions for child maltreatment ended up coded as kind of the primary maltreatment symptoms that Dr. Jane mentioned earlier in the presentation. The vast majority are for substantiated or we assume are substantiated based on the way that they're coded in the discharge data, I should say, with a much fewer number being related to just examinations for potential neglect. And then the very smallest number is for kind of these other other problems related to upbringing, which are more conditions of neglect. Something else we were really interested in just taking a look at when we looked at the data from a kind of bird's eye view was we know how many children are being admitted to the hospital, but also we're curious as to how many were being admitted to the intensive care unit. And on average, over the course of this entire study, about 10 to 15% of hospitalizations end up admitted to ICU. And I know Dr. Jane will speak a little bit more maybe about ICU cases or some of the factors that are assessed for during a hospitalization for maltreatment later in the talk. But again, these would usually be the most severe cases if they have a injury that either has put them at a level of medical risk or a suspicion of developing a level of medical risk that requires that really like one-to-one intensive care, critical care environment. And then finally, we looked at the overall kind of median length of stay, which has again been more or less unchanged. When these children come to hospital, they tend to be in hospital in kind of the 2 to 3 day range. Usually, like longest is kind of 8 days. The shortest might be 1 day, and that would probably be a case where there's not really a strong suspicion for child maltreatment, and it's a very brief admission. Okay, so here is the kind of actual findings of our study. And this first slide is our interrupted time series analysis of hospitalizations for child maltreatment in children less than 2. So just to break down this slide for folks, when we're looking at this, the solid orange line is the number of hospitalizations in terms of the rate per 1 million population that we're seeing for every 4-week period during the study. So the solid orange line is the actual calculated rate based on the data that we have. These little dots that are everywhere were the actual numbers for every 4-week period. So really you can think of, in some ways, of this orange line as being as averaging out the average rate over time for each of those 4-week periods based on these dots. When we hit the gray bar, which is the pandemic period, we'll see another line appearing. So the dashed line is what we'd call the counterfactual or the expected rate. So this dashed line is based on the pre-pandemic period using statistical modeling, how many admissions we would expect to see for each 4-week period. And so starting with March 2020, we're able to compare what we expected to see in the dashed line to what we actually saw, which is the solid orange line. And what you see and what we found in this analysis was that during that initial 16-week period of the most stringent pandemic measures, which is represented here by the solid gray bar that goes almost through the middle of the slide, there was a very significant reduction in the number of expected admissions for child maltreatment. So you'll see that solid orange line is well below the dashed orange line. The amount of hospitalizations we actually saw was far below what we would have expected from statistical modeling. And, this certainly raises a lot of concerns for us because, at least for our research team, our estimation is that there was probably at best no difference and at worst an increase in the risk of child maltreatment during those really stressful, stringent days of child maltreatment. There's lots of literature that shows us that in times of societal stress, family stress, rates of child maltreatment tend to go up. And so it's quite concerning to us that in this time of greatest stress, rather than rates of the most severe cases increasing, the hospitals, we actually saw them go down. So I'll speak a little bit more about that in our interpretation later. Interestingly, though, almost immediately after the 16-week pandemic period, we see the actual rate almost mirroring the expected rate. So as you can see here, by basically like July of 2020, the rate of actual hospitalizations, the solid line, is almost exactly mirroring what we see in the dashed line. So really, once those strictest measures were lifted, there was a return to the kind of expected number of hospitalizations. And I mean, I think we all wish for a society where we don't need to admit children at all for maltreatment. But the reality is that I think right now we expect there to be a somewhat steady rate. So I think we actually interpret that as a reassuring sign that after the most stringent pandemic health measures were lifted, we started to see what we expected in terms of child maltreatment admissions. The second thing that we looked at were rates of ICU admissions. For this data, we actually do not have data from Quebec. So this just includes the provinces and territories other than Quebec. And I know certainly part of my work, in addition to my community work, is working inpatient at BC Children's Hospital. As you mentioned, Dr. Jane is a child maltreatment practitioner there. I think a phenomenon a lot of us witnessed was maybe an increase in really severe cases. And so we thought we wanted to do the best we could to see whether there was any trend in the change of the most severe cases. And so the best definition we could do for that based on our data set was those that were requiring ICU admission. And so we did an interrupted time series analysis. We had to use slightly different periods. So rather than calculating admissions for 4 weeks, we used 8 weeks just because there's less overall admissions and we wanted to be able to do the statistics appropriately. But otherwise, the methodologic approach was the same. Similar to the last slide, the solid orange line is what we actually saw, and the dashed line is what we expected to see based on the pre-pandemic trend. And here for ICU admissions, you actually see a different story. During that initial 16-week pandemic shutdown period, you see, a slight decrease compared to what we would have expected. So I guess more or less matching the trend that was seen in the overall hospitalizations. But interestingly, starting in about July of 2020, and for about 18 months after that, there was actually a higher than expected rate of ICU admissions compared to the expected trend from before the pandemic. So you can sort of see that maybe between 2016 and 2020, the rate was maybe steadily slightly decreasing, which is what the model kind of shows with that dashed line. And what we actually saw in terms of ICU admissions following the pandemic was a relative increase following that initial pandemic stringency period. And I think one of our hypotheses is that it may be that during that stringency period, when there was a real decrease in services for families, there was an opportunity for some more really severe cases to develop, and then they just presented more slowly and insidiously over the preceding time, rather than acutely during that initial COVID shutdown period. So, like I said, those are the overall conclusions of our study. And I think they do provide some, interesting features for those of us that work in hospitals and are part of child and family health policy to consider. I want to be really clear, and I think I've already said this a few times, but this data is only taken from hospitalizations. It cannot be extrapolated at a population level of child maltreatment during this period. And so certainly, Dr. Jane mentioned these 5 types of neglect, sorry, 5 types of maltreatment. Things like neglect, sexual abuse, emotional abuse are probably less likely to be reflected in this study because they're less likely to require hospital admission. And Dr. Jane will be kind of talking through a case of a, maybe typical hospital admission for child maltreatment in a young child. Because of the way this study was designed using available health information, we have missing data for those that do not have active provincial health numbers. So folks that have precarious or undocumented migrant status, for example, were not included in this study. And then I think it's really important to remember that the way these studies are done, it's completely contingent on how a hospital and usually an administrator codes a discharge from a hospital. And so there is always a risk of some coding inconsistency with use of ICD-10 codes. There's lots of studies that are done to try to look at and show, especially in big studies like ours, that this is still reliable, but we just need to acknowledge that there's always a risk of inconsistency. So in terms of our kind of like big takeaway points, what we saw in our study is that incidence rates for child maltreatment hospitalizations declined during that initial 16-week pandemic period. And we think that that's most likely secondary to not a population level decrease in maltreatment, but rather the fact that overall health hospitalization was lower. So people just weren't bringing their kids to hospital. So we're worried that we might have been potentially missing severe cases of maltreatment during that initial pandemic period. Following that time, our rate of overall hospitalizations returned to normal, but there was a period of about 18 months of increased ICU admissions. So the total number coming to hospital was the same, but more of those cases were more severe, requiring ICU level care. And I think that maybe speaks to some of the ongoing potential consequences of stringent public health measures and their effect on families and family well-being. And so I think the big kind of question to think about, and something that we know that really happened during the pandemic, is a lot of reduction in opportunities for services for families. And so one thing I think about is how can we minimize the interruption in services that support families in future pandemic or future emergency states to minimize these impacts on children? Because we don't want to have children that need treatment not presenting to hospital, and we also don't want more children coming to ICU than were previously. And I'm just going to really quickly acknowledge specifically my primary co-authors, Nadia Romeliotis and Quinn Dewan, as well as Carolyn Quash-Tan, who is our network director, and Silvana Cote, who provided a lot of senior expertise, as well as the rest of our popcorn pillar leads and the CMAJ manuscript co-authors, specifically from Ines, Mike Benegari, and Mamadou Diop. Our amazing biostatistician, Melissa Burchell. I was not coding this in R, so a huge thank you to Melissa for all of her skills. and then our amazing popcorn operations team, Sarah Hira, Marianne Rufiange, and Britt Udall, who supports us here locally. And with that, so now that we have that context of what happened during the pandemic in terms of hospitalization trends, Dr. Jane, who's an expert in maltreatment, is going to kind of talk us through what does that hospital care actually look like for children that are admitted. So Dr. Jane, back over to you.
Great. Thank you, Matt. Okay, so I'll have you move to the next slide, please. I thought it would be helpful to share a composite case with you to really illustrate what a clinical scenario might look like for a child who is going through the hospital setting. So let's talk about baby G. This is a 3-month-old girl who was previously healthy and well, presented to the hospital with a sudden onset of apnea, which is basically a stoppage in breathing. She was brought to the emergency department by ambulance, and on initial examination was noted to have some bruising on her face and on her left thigh. Because of her clinical presentation with her level of consciousness being decreased, she underwent an urgent CT scan, which showed evidence of a skull fracture and some subdural blood, which is bleeding around in the space around the brain. On history, there was no history of trauma provided by the family. She was brought in by her family. She was described as being a healthy baby. She'd had a 2-month baby check, and everything had checked out well during that time. The previous medical history showed that she had been seen in the emergency department on 2 occasions. One when she was about 3 weeks old for a stuffy nose, and she was discharged with just conservative management at the time, looking well. And then interestingly, at about 2.5 months of age, she was seen for a bruise to the right side of her jaw. And at that time, the emergency physician informed the family that this was normal and babies are very fragile and it's okay for babies to bruise. And with that, the baby was discharged home. Next slide, please. So in cases of child maltreatment, early recognition is really, really important, and it can make a big difference in the outcome for a child. Complicating matters in these cases is the fact that their presentations can be very nonspecific, meaning they can look like many different conditions. And so you really have to have your eyes wide open and be alert to red flags. So red flags on history that are really critical to be thinking about is when you are provided with a vague history of an injury, or in fact, no history of trauma at all. So a child that has sort of this miraculous or magical injury with no history of trauma that precedes it. Also denial of trauma despite the presence of very obvious injury. Be wary of changing explanations for the injury, and beware of injuries that aren't compatible with a child's developmental status. So for example, a 6-week-old baby is not capable of rolling off a bed. They just aren't capable physically. They don't have the developmental gross motor skills at that point to be able to do that. And another red flag can be delay in seeking care. So where an expected amount of time has passed between the time of the injury to the child and the presentation to hospital. Then there are also red flags on examination to be aware of. Any bruising in a non-mobile infant, and non-mobile infants generally tend to be those that are less than 6 months of age, and I'll talk a little bit more about this in a slide coming up shortly. Unexplained loss of the use of an arm or a leg, or multiple or patterned bruises or burns. Next slide, please. Early recognition of physical child maltreatment has been aided by understanding the concept of sentinel injuries. This really has, I think, been quite revolutionary for those of us that work in this field. So a sentinel injury is defined as a seemingly trivial injury, such as a bruise, that's concerning for abuse, that's reported to have been seen by at least one caregiver preceding the event that's brought the child into care at the moment, and the current presentation in the child being now a much more severe presentation than that initial bruise. In the case that I just presented, you might recognize that the bruising on the jaw of the baby at 2.5 months of age was a sentinel injury. So when that sentinel injury is recognized at the outset, there is really a good opportunity to prevent further or more serious injury to the child. I like to teach medical students and residents that the presence of a sentinel injury indicates the need for immediate investigation and action. In fact, I will often say this is a medical emergency, which may be a bit counterintuitive to people. A bruise on a child, a fairly common injury, but really in young children, a bruise should be considered a medical emergency requiring further investigation. And then in a now seemingly old, but really still very relevant study from 1999 called Analysis of Missed Cases of Abusive Head Trauma, the retrospective reviews of 173 cases of abusive head trauma in children less than 3 years of age, pardon me, showed 54 of the children, that's about 31%, had been seen by a doctor for a minor injury, which was not recognized in the healthcare setting, and ultimately 5 of those children died. Next slide, thank you. On this slide, I wanted to share with you a really simple but effective tool for recognizing sentinel injuries in children. Mary Clyde Pierce and colleagues in Chicago have developed this validated clinical decision rule called the Bruising Clinical Decision Rule, which they've named with the mnemonic 10-4 faces P, which I love the catchiness of that, making it quite easy to remember, to help predict abuse in young children based on the characteristics of a bruise. So I'll break this down a little bit for you. The mnemonic 10-4 stands for bruising on the torso, ears, and neck in any child under the age of 4 years of age should be considered worth investigating. But it also refers to any bruise anywhere on the body in an infant of 4 months of age or less because of their non-mobile status. And so that's just incorporating the TEN and then the 4 for age 4, but also for 4 months of age. The faces portion refers to the areas on the body where injury is more likely to be due to abuse. And the small p refers to the presence of bruising in a recognizable pattern, such as maybe a handprint. In my opinion, this tool really has been revolutionary in that it's simple and easy to follow. And when you're working in a busy office practice or a busy emergency department, being able to pull something like this up and do a quick check based on what you're seeing in your patient in the clinical setting can really be valuable. Next slide, please. In this slide, let me share with you the principles of assessment when a case of child maltreatment is suspected. So we recommend admitting the child to hospital to ensure their immediate safety. And I just wanted to go back to a point that Matt mentioned about the days of hospitalization. For those cases where you might have had a child that was hospitalized just for a day or two, in fact, it may have been what we call sometimes a social admission, just to ensure that a child is safe and well while things in the community, for example, safety in the community and protection-related matters with social workers are being sorted out. And it may also be situations where children are undergoing a quick battery of investigations, but they're otherwise clinically quite well. So when there's concern for multi-system trauma, such as the case that I'm presenting to you, the hospital trauma team should be activated and subspecialty teams should be consulted as needed. And you can see I've listed here for you a few of the subspecialty teams that are regularly or routinely involved with our cases. Almost always we have involvement from radiologists, sometimes neurologists and neurosurgical teams, general surgery teams, orthopedics, of course, in cases when children sustain fractures, and ophthalmology is also an important service that we consult regularly, especially when we're talking about head injuries. The investigations for children that are being assessed for child maltreatment can be divided into 2 pathways. The first being medical, and always the priority, of course. These are the investigations that aid in injury detection and management. And then secondly, a child may require forensic investigations to detect additional abusive injuries that may not be apparent on physical examination. We call those occult abusive injuries. And then a systematic multidisciplinary approach with a physician, social worker, nurse, in a trauma-informed way is recommended, with special attention to remaining objective and really putting our biases to the side and not taking on the role of law enforcement or child welfare. Our we talk about staying in our medical lane, which is really, really important, as is transparent communication with caregivers, which we consider to always be best practice. When appropriate and when available, it can be extremely helpful to involve Indigenous advocates or cultural liaison services within your hospital setting for these types of cases. Next slide, please. So going back to our case of baby G, who presented with bruising on the face and the leg and was subsequently found to have a skull fracture and bleeding around the brain. On further testing, multiple additional injuries were identified in this baby. The MRI of the brain showed that there was more bleeding and some lacerations, or I'd say sort of cuts in the actual brain tissue. And there was also evidence of oxygen deprivation to the brain. The eye exam, which, as I mentioned previously, is often done in cases of abusive head trauma, identified multiple hemorrhages in the retina of both eyes. A CT scan of the abdomen was done and it identified traumatic injury to the liver. And then an investigation, an interesting one called the skeletal survey, which is a series of x-rays of all the bones in the body, can be really up to about 20 or 22 x-rays, showed multiple fractures of the ribs, legs, arms, and skull. And these fractures were seen to be in various stages of healing, and some of them were considered to be high specificity for child maltreatment. And I won't get into this in any detail, but there are some types of fractures that are really considered to be very high specificity for child abuse and not seen in any other situations in children. The skeletal survey itself is a really common investigation that we do, and it is considered mandatory for all children under the age of 2, mainly because of their nonverbal status at this point, when there are concerns about suspected child physical abuse. So in this baby's case, baby G, unfortunately, we did a tally of 42 fractures in this 3-month-old child. Other testing was also done, which showed no increased tendency to bleeding or bruising. And that was helpful because it helped us recognize that there was no underlying medical condition to explain the bleeding or bruising. And there was no evidence of bone fragility when looking at some of the bone markers to explain the multiple fractures. And so despite extensive testing, there was no medical explanation for the findings in this baby, and there was no history of trauma provided to explain the injuries. Next slide, please. And that leaves us in a really challenging position because child maltreatment is the #1 consideration on the diagnostic list. And so we find ourselves really formulating a diagnostic opinion that can be very challenging. But it is important to clearly state the injuries in this opinion and the results of the investigations that looked for other causes or explanations for the findings. So I included this slide here because I think I often get asked by students and residents about how to articulate this into a medical report because it can be so contentious and emotions are obviously very, very high, and there is a possibility of legal proceedings. So I might use language such as the constellation of severe injuries involving multiple body systems, including the brain, eyes, liver, bones, and skin, in the absence of a significant accidental traumatic event. And what I'm referring to there is a major traumatic event, such as a major motor vehicle accident, is extremely concerning for the diagnosis of child maltreatment. The presence of fractures in different stages of healing implies inflicted injury on more than one occasion, and the most likely diagnosis in this case is traumatic head injury due to child maltreatment. I can break that down a bit further to comment on the significance of each of the injuries and that they can't be the result of birth trauma, because sometimes that is what families are hopeful for, that this was something that was sustained during the process of birth, but 3 months out, that's not a feasible possibility, or an underlying medical condition. And that is why we do some of the investigations to ensure that we haven't missed anything that is relevant in terms of a medical condition. And it's very important to document all of your findings objectively and thoroughly, because many of these cases do have a possibility of ending up either in criminal or family court. Next slide, please. I mentioned earlier that I was going to talk a little bit more about reporting in Canada. So reporting to child protection authorities is a legal duty for anyone, not just medical professionals, but anyone in society who suspects child abuse or risk of harm to a child. And your threshold for reporting is just to have reasonable grounds to suspect. And the language, for example, written into the BC legislation is likely to be a risk of harm or the likelihood of harm. So proof is not required. As a reporter, you do not have to prove anything. And we would encourage you to report even if a situation is not clear for a particular child, because there may be other children in the home that are at risk. And for those that have questions about what happens for children who are of Indigenous background, please know that although the reporting agency may not be the Indigenous agency that you report to, for example, in British Columbia, we would report to the Ministry of Children and Family Development. They will then forward on the case to the local Indigenous Child and Family Services agency as needed and as available, because of course not all jurisdictions have the Indigenous Child and Family Services available yet. And then just to demystify a little bit about what happens once a report is made to child welfare, it is the child welfare social worker's responsibility to meet with the family and create a safety plan while they are undergoing a child and family risk assessment. The safety planning may include either no access to the child, supervised access, or complete removal, which is oftentimes the biggest concern that reporters have, is that children will be unnecessarily removed from their caregivers. But it's important to note that this is really the very last resort, and there are a number of other options that social workers consider prior to removing a child from their family of origin. And then always a recommendation for siblings, especially young siblings under the age of 5, within the family, to also undergo a medical assessment. Next slide, please. I briefly wanted to touch on SCAN teams, or suspected child abuse and neglect teams in Canada. That is the type of team that I work on here at BC Children's Hospital. SCAN teams are multidisciplinary teams with physicians, nurses, nurse practitioners, social workers, and psychologists, and they are found in most large hospitals and some smaller centers across the country. We receive referrals from the community, generally from social workers in the community or from physicians. And our role really is to provide comprehensive child maltreatment assessments and come up with those diagnostic formulations like I shared with you on an earlier slide. And we then really become sort of the go-between between the medical system itself and the child welfare system or law enforcement. So we take on the role of communicating the injuries a child has sustained, what the relevance of those injuries are, and those types of things with social workers and also with law enforcement when needed. As well, we often attend court proceedings as expert witnesses with the role of educating the court on the medical findings in specific cases and their relevance and association with the diagnosis of child maltreatment. Next slide, please. Okay, so just to finish up, a few key takeaway points. Child maltreatment is common in Canada. I hope the statistics that we have presented and shared with you today show that clearly. Outcomes can be very serious for children. These are young people that have that are in the early stages of development and still really developing their brain and their developmental skills. And there are cases even where child maltreatment can be fatal, unfortunately. Early recognition is really critical, and it relies on the awareness of red flags and the use of validated tools, such as the one I presented to you called 10-4 Faces P. Child maltreatment assessments must be and should be systematic, trauma-informed, and multidisciplinary. Mandatory reporting is required whenever child abuse is suspected. And if you have any questions, any concerns, please always think of your local SCAN team and reach out to them. We're always available. Our team in particular is available 24/7 with an on-call physician to provide any advice that you might need and help guide you towards for either further medical investigations or around the issue of reporting to child welfare. That's great. Thank you very much.
Thank you, Nina and Matthew, for this really valuable evidence and your insights, as well as your guidance for members of Children's Healthcare Canada and the people who work within them. And I see we've got a couple of questions that have come in. Davey asked, why were the Quebec data on ICU admissions not included?
Yeah, that's a great question. And it was truly just a process question because this study required a data sharing agreement between High, where we were holding our data, and INES. When we did that agreement, we'd only asked for hospitalization data and not the ICU data, and the ICU analysis was a secondary analysis. So we just simply hadn't requested that data and weren't able to go in post hoc and request it
Oh,
with our agreement with INES. That data is available in Quebec. Any Quebec-based investigators could access that through a conversation with Ines.
wonderful. Thank you. I wondered if it was sometimes the province and hospitals within it don't share data nationally, and I wondered if that was the case, but apparently not. Chantal asks, will the slide deck be available via the portal? And with your permission, we would gladly post it along with the recording. But let me know if you have any objections. Another attendee who remains anonymous. How do we prevent misguided child maltreatment reports when it comes to children with disabilities? Families of children with disabilities experience more reports than those without, many times because outsiders don't understand the condition.
Yeah, that's a really great question. I think the responsibility then lies in the folks that are actually that are receiving the report and doing the investigation. And so we do, a clinic like ours, for example, we'll see children like this that are brought in for assessment. I'll give you a quick example. A child that is, say, with cerebral palsy, is in a wheelchair and has bruises across the thighs, and the concern that these might be inflicted bruises when in fact they could just be from the straps that are used to secure the child's limbs into place so that they're safe within their wheelchair. And so we can do these types of assessments and really with the pediatric knowledge of knowing what these children, what their underlying medical condition is, what some of the supports are that are necessary and required for them. For example, a child with cerebral palsy may have uncontrolled or involuntary movements, which is why they need to be restrained with straps, and those straps, if they push against them, can lead to bruising. I think really the onus is on those of us that are doing the medical investigations. So in an ideal scenario, if a report were to be made on a child with disabilities to a child welfare agency, that agency should be seeking a medical opinion and bringing those children into a clinic such as ours for a multidisciplinary assessment.
Thank you. Great advice. Andrea comments saying that thank you for an excellent presentation. It was a great blend of data and a case study. She's got a question about the data presented on rural and remote children living in rural remote communities. It looked like the incidence was even lower during the pandemic. She wonders if that's true or if she's misinterpreting the numbers. And she figures that scan teams are primarily in urban hospitals, but she wonders, do they consult to more community hospitals?
Yeah, that's a great question. So just regarding the data, you are correct that if we had done a separate time series analysis looking at only rural and remote, the effect of decreased hospitalizations was even more profound in those communities. So the baseline rates per population are higher in rural and remote communities, and they had kind of a greater drop during that, especially that 16-week period. Just with numbers and statistical modeling, we couldn't maintain the integrity of the model, we say, with the numbers being as low overall as they are, which is obviously a good thing. So hesitate to share like a full time series analysis, but you're correct that that's the trend. And if we broke down the rates a little bit more granularly, which is if somebody reaches out to me, we can help do, you would definitely see that trend. And I'll maybe turn it over to Dr. Jane to answer the question about presence of scan teams, but I know in BC, at least historically when I was training, there were groups in several communities outside of Vancouver that had scan teams. But certainly the most kind of in-depth multidisciplinary team is at our tertiary hospital at BC Children's.
Yeah,
Fair.
I can tell you that in British Columbia, we have 5 health authorities in our province here. Each of the health authorities has a scan team. Ours here at BC Children's, because of the location at the tertiary, the one and only tertiary care hospital in the province, ours is the biggest and probably the best, the most available team. As I said, we have the 24/7 on-call service, but we do have regional scan teams in the 4 other health authorities. I see a question in the chat that was similar to this, and so hopefully can answer that altogether. In rural communities, you would refer to your local scan team. So that might not be locally within your village or town or small city, but to your region. So an example I can give to you is the small community of Fort St. John in northern BC would refer to Prince George, which is a regional center in northern British Columbia, and that is a scan team that would take on a case like that. And we are all, well aware of our regional jurisdictions that we cover within our health authorities, and larger centers such as ours may actually take on cases from elsewhere in the province. For example, if that child from Fort St. John that I'm mentioning hypothetically were to come to BC Children's Hospital for medical care, then that would default to the team here at BC Children's Hospital. With regards to finding scan teams in your areas, we don't do such a good job in the medical system of highlighting the clinics and the services that are available throughout. I can say that for us in British Columbia, and it may be the same in other provinces. There are certainly lots of clinics that run at Children's Hospital that even some of us that have worked here for many years don't know about. I would encourage you to reach out to your local children's hospital, be that in a smaller city or your big sort of provincial tertiary care children's hospital, and ask them about regional scan teams. There really are multiple teams located in the bigger provinces. So Ontario, for example, has a number of them, as does Quebec. Some other provinces, such as Saskatchewan, Manitoba, are less well represented with scan teams, but they do assessments from all over the province. So children are sometimes having to be flown down to these areas to have their assessments done.
Thank you. Just building on that, are there, perhaps this is a silly question, but in the move to more virtual care, are there virtual options for scan teams to work with local service providers to conduct a scan without having to come down into a major tertiary center?
Yes, absolutely. Such a good question. And I would say even before the pandemic and this explosion of virtual care that we've seen since then, this is something that we've been doing for many, many years, where we provide telephone advice to other physicians and healthcare providers. So again, our team being the one that has that 24/7 call responsibility, may take a call from another region in the province where we can provide some advice to the local emergency physician or pediatrician about which investigations to do, what to look for, and how to formulate an opinion without having to have the child be transported down to the major center. We can certainly assist and aid with that. And I suspect that's how it works in many of the other provinces in the country as well.
Thank you. Chanel comments very positively on your webinar, found it very insightful. She said, a lot of us working with children have lived and loved experience with scan teams and professionals and are aware of the benefit and the need for combating child maltreatment. But her question is, who isn't here listening to this, who should be, and should be aware of this work? And what are you folks doing to, apart from this webinar, of course, but to share the importance of this more broadly?
Yeah, such a good question. It's not very, it's not the kind of work that people gravitate towards, let me tell you. It's hard to find people that are interested in doing work in child maltreatment, as important as it is. It is very time consuming. These cases take a very long time to, formulate a diagnosis, and there's a lot of there are a lot of difficult conversations between the physician group and families. So not something that really people want to do very often. How do we get this message out? Well, as SCAN teams, we do have a responsibility written within our contracts to provide education, such as something like the webinar we're doing right now. But we regularly provide education to community social workers working in child welfare, to medical students, nursing students, social work students, residents in various different medical specialties, and physicians and nurse practitioners that are already living and working in communities. We do quite a lot of education for them. That said, I'm still surprised almost every day by the number of people who will say that they had no idea that teams like ours existed. And that's unfortunate because it is we can really assist practitioners, especially during their very, very busy and challenging days, either in the hospital or in their community practices, when they come across cases like this. So get the word out from your end as well. We are here, we exist, we are happy to take referrals and see children, and at the very least, at least provide advice on how to manage these cases out in the community so that, ultimately, everybody feels like they're doing the right thing and children are safe and protected.
Absolutely. Thank you. The very last question, and Nicola acknowledges this is more of an emotionally driven question, but are you able to share if 3-month-old baby G survived or how she's doing?
Yes. This was a composite case, so it was not just one baby; it was a number of babies put together. But this the case that I can picture in my mind, that was sort of the basis. The baby has done very well. I suspect baby will have some brain-related cognitive and developmental disabilities over time as a result of the brain injury, but the fractures heal beautifully. The liver injury, the skin injuries with bruises, they all heal really beautifully in children of this age. As I said, cognitively and developmentally, it remains to be seen. And so she will be followed closely by a brain injury program and a pediatrician in hopes that that she will meet her expectations of what life holds for her.
Definitely an integrated approach then to the care of baby G.
That's correct.
Thank you both so much for sharing this important information, this evidence, and your insights. As I mentioned to Matthew at the beginning, I once worked in the downtown east side, and all of this resonates, and that was a million years ago, but it still resonates with me. But that's the end of our time together today, and thanks again for sharing your time and expertise. Thanks to those of you who attended and asked questions and were engaged in the discussion. We hope you depart with some practical knowledge to bring back to your organization. And upcoming, we'll be hosting a few additional offerings. Tomorrow, Children's Healthcare Canada is pleased to co-host Advancing Youth Suicide Prevention, Learning Across Borders with our sister organization in the US, the Children's Hospital Association. On Monday, December 15th, we brought you a just-in-time podcast related to the viral respiratory experience in Australia with lessons for the Canadian healthcare organizations and professionals called "'Tis the Season, Flu, RSV, and COVID, a Heads Up from Down Under." In November, we released the latest edition of the Spark Conversations webinar series focused on right-sizing. This is Right-Sizing Children's Healthcare, the critical role of community-based developmental care. You'll listen in as Dr. Catherine Smart discusses community-based developmental healthcare in right-sizing children's health systems with guests Jennifer Churchill and Allison Morrison. Join us at the Hyatt Regency in Calgary on May 31st to the June 2nd for our annual conference 2026. Registration will open early in 2026, and nominations for our Innovation and Impact Awards will be accepted until December 22nd. Check out our conference platform for more details. I mentioned in the chat about our member portal. Connect with the child health community through our new member portal. It's a secure collaborative space designed exclusively for members to connect, share resources, and engage in discussions that advance child and youth healthcare. And on this platform, you'll find dedicated spaces for all our networks, exclusive content, discussion spaces to connect with fellow members, and information on the latest initiatives, events, and advocacy efforts. To create your account, visit the Children's Healthcare Canada website, children'shealthcarecanada.ca. Click on the member portal in the top right-hand corner, and then create. And lastly, Spark Impact is Children's Healthcare Canada's knowledge mobilization and consultation and support service for child health and health system researchers. Through Spark Impact, Canadian researchers can access a knowledge mobilization specialist for support in developing their knowledge mobilization plans for grant submissions, as well as a variety of knowledge mobilization products and services and tailored supports to help you achieve your goals, expand your reach, and improve research impact. For more information, visit the Children's Healthcare Canada website. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on the member portal. Thanks again for joining us today. Thanks to our wonderful speakers for this presentation, and hopefully we'll see many of you back here soon. Bye for now.